Welcome, everybody, to Wonderful Wednesday. And today we're going to talk about unstable tachydysrhythmias. How do we know what to do? Oftentimes, we'll seem quite confusing. One group of physicians orders one thing, another group orders something different. And a lot of it really just depends on how we're diagnosing the patient, how stable or unstable the patient is, and our overall understanding of what it is we're trying to do. So first and foremost, with all arrhythmias, but particularly when we're talking about tachydysrhythmias, there's one basic rule, and that is diagnose before treatment, if possible. Now, make sure you appreciate diagnose before treatment, unless it's an emergency, right? If it's an emergency, the patient is pulseless, he's profoundly unstable, he's in shock, that's an emergency. Treat first, ask questions later. But if you have time, try to diagnose before treating, because some therapies that you might introduce may actually exacerbate or worsen the dysrhythmia. So if possible, take a breath, be calm. If the patient is not unstable, he might be a little diaphoretic, he might feel woozy, but he's got a relatively stable blood pressure and a pulse. Wait for a minute and try to evaluate what's actually occurring. Now, really, really important for us to remember that a lot of times when we just react, we can actually cause some significant dysfunction. And that's why it's really important to try to obey this simple rule: diagnose if possible before treatment. And then just thinking about diagnosis, there really are three basic things, right? Heart rate, what is the rate? Whether the QRS complex is wide or narrow, whether it's regular versus irregular, and of course, whether or not the patient has a pulse, and whether or not he is stable or unstable. So remember, all those rules go out the door. If your patient is unstable or pulseless, don't worry about diagnosis. Treat first, ask questions later. Okay, so want to remind you that your monitor can be very misleading. Now, I think there are very few places today where you don't actually show two leads of your EKG. But most of the time, what I walk in the room and I see is the first channel is lead 2, and the second channel might be a lead 3. It could be an AVF, it could be a lead 1. I want you to really think about how you're encircling the heart in order to actually evaluate appropriately your patient's dysrhythmia. So first choice typically is lead 2, because the parallel that is drawn between the right arm electrode and the left leg electrode, which is on the left lower chest, actually correlates or parallels the electrical activation of the heart. So in general, lead 2 is a really good first lead. But then we need to think about having something that looks at a different view of the heart. And my choice would always be to take your brown electrode and put it on the fourth intercostal space on the patient's right side of the sternum. That will be a V1 lead. Now, that's if you have a 5-lead cable. Obviously, you have to have a 5-lead cable to look at a chest lead. So my choice would always be, particularly in a patient who's at risk for dysrhythmia, particularly if I want to be able to visualize P waves, which are incredibly important, I really want to have lead 2 first and V1 second. So my primary lead 2, my secondary V1. V1 gives me a beautiful view of P waves, as does lead 2. And when you think about most tachydysrhythmias that are not ventricular, you're really looking for the P wave. You're looking for the P wave morphology, the continuity, and whether or not it is regularly connected to the QRS. So you really need to choose good leads for that. That seems to me to be really important for us to learn as bedside nurses, to precept others, to think about lead 2 and V1. Now, those things are going to change depending on the patient's pathophysiology. Have they had a great big inferior infarct? Then you're not going to want to choose lead 2 since that's an inferior lead. But in general, the first leads we're going to place lead 2 and V1. So be really familiar with that and remind yourself that you're really trying to encompass the heart in a better visualization. You want to be able to see P waves clearly. Lots of times people are like, oh, I don't really care about P waves. What are the P waves? Why are they important? They're really important when we're talking about AV nodal reentry, when we're talking about profound sinus tachycardia, when we're really trying to differentiate issues of bundle branch block and wide QRS morphology. We really need to be able to see that P wave. Your P waves are not seen clearly in almost any of the other leads, but they are typically seen clearly in lead 2 and V1. That's why we'll choose those. Now, that's also going to help us in interpretation of the QRS morphology. And of course, regular versus irregular really requires that you visualize the EKG. Sometimes it requires that you've recorded the EKG, either doing a rhythm strip with a 12-lead EKG, or you're recording from your EKGs from your bedside system. That allows you to really look at whether or not it's regular versus irregular. And the thing that's really important, and I learned this very early on in my career in the late 70s, I worked with one of the first electrophysiologists in the world, Jeremy Ruskin, was that it was really important when you are providing therapy, if possible, to actually have a 12-lead EKG applied and actually look at rhythm strips of lead 2, V1, and V6 continuously as you provide any type of intervention that's going to interrupt the rhythm, if it's possible. If you had a code, obviously the EKG tech is there. Make sure that they're considered part of your team, that they don't just come in and leave. They can help you really focus on unifocality, multifocality, differentiation of AFib or A-flutter, particularly after administration of adenosine. So it's really going to help us to evaluate the substance of our patient's tachydysrhythmias. So just to reiterate, if possible, always have lead 2 and V1, or consider V1 and a modified V6. With a 12-lead EKG, when you're looking at rhythm, so you call your EKG tech, they think you're looking for a STEMI. They're going to do those little short bursts, less than 3 seconds from each lead, but you need a rhythm strip. When you're looking at rhythm analysis with a 12-lead EKG, which is the best way to do it, you need to ask for a rhythm strip. So you're going to get at least 16 seconds, but sometimes you need that to run even longer. So the most basic is to say lead 2 and V1. But if you've got a little bit more experienced EKG tech, or you yourself are performing the EKG, you really would like to have lead 2, V1, and V6, so that you're actually applying an inferior lead, a right-sided lead, V1, and V6, a left lateral lead, giving you a really good view of origination of the foci that is causing a disturbance to your electrical rhythm. So incredibly important. So Barbara's rule of thumb is the very first thing when you're looking at an EKG, we're not talking about looking for STEMI or non-STEMI, we're talking about rhythm here. So are your P waves regular, which means I use an index card, I make a little mark from P1 to P2, and then I move my index card along saying is P1 to P2 the same as P2 to P3, the same as P3 to P4. So are my P to P intervals regular? And do they match my R to R intervals? So typically I use the peak of the P to the peak of the next P, and the peak of the R to the peak of the next R. And I want to be sure that P to P equals R to R. And that's really important. It's a very simple step. It seems to me that it should be taught in every single basic EKG class. I don't know how you can pass a basic EKG class if you don't know how to look at P to P and correlate that to R to R. And you have to do that across a strip. You have to have at least 10 or 12 beats to look at in order to say these are regular and they match. And then finally, you'll look at the PR interval. So from you can, however you choose to do this, you can do it from the peak of the P to the peak of the R, or the S wave if it's downwards, to just say these intervals are absolutely constant. Make it easy on yourself. Just make it the easiest point of accessibility and measurement. And then finally, you're going to look at what is the width of the QRS. Remember that normal QRS width from beginning to end. So that means if you have a Q wave and an S wave, or if all you have is an R wave and you don't have a Q wave or an S wave, the width should always be less than 0.12. Anything greater than 0.12 indicates that you have some electrical dysfunction. If it's greater than 0.16, you absolutely have a bundle branch block. But from 0.12 to 0.16, you might have an incomplete block, particularly when we're talking about the left bundle, which has 2 divisions. So really, really important when we're evaluating our patient that we're using that information. Now, I want to make sure that we appreciate there are 2 different tachydysrhythms. And the reason we under 2 different classifications of our tachydysrhythms, again, not really focusing on VFib or VTach. Pretty much everybody's good with that. I don't think that you could be taking care of a critical patient and not have some idea about VTach and VFib, although I think sometimes we make some mistakes. But it really is important to say when we look at tachydysrhythms, we classify them based on the disorder. Are they problems of impulse formation, meaning that you are firing an impulse from a lot of different abnormality or different areas that are particular, but regular impulse? So sinus tach, atrial tach, premature atrial or sinus, premature atrial depolarizations, junctional tachycardia, which is accelerated idioventricular junctional, or junctional premature depolarizations, versus an absolute disorder of conduction, which is really very important to appreciate, is that you have these firing impulses and they may be reconducted up into the atria. And so categorically, we're going to say impulse formation tends to be more of the basic tachycardias, and impulse conduction tends to be things like AV junctional, reentry tachycardia, atrial fibrillation, atrial flutter. Now, don't be worried. There's a lot of words spreading around here. I just want you to appreciate that categorically, we're going to treat these 2 somewhat differently. Because if it's an impulse formation disorder, we're going to try to control the formation. If it's an impulse conduction disorder, either because you have reentry or because your junction is transmitting these abnormal impulses, such as an atrial fib or atrial flutter, at a very rapid rate, you've got to look at that conduction, and you're going to control first and foremost the conduction time. That's why you give things like beta block or calcium channel antagonists. Hopefully they'll control the impulse, but that's more about controlling conduction. So impulse formation disorders and impulse conduction disorders. But let's make it even more simple than that, okay? And this is really simple. Anything with a sustained heart rate of greater than 100 is going to be considered to be a tachydysrhythmia. Now, it doesn't mean that it's life-threatening, right? It doesn't mean that your patient's going to be unstable, but if the heart rate is sustained at a rate greater than 100, we're going to consider that a tachydysrhythmia. Now, first, we're going to look at sinus tachycardia. I don't have that up here. What I have here is atrial tachycardia. So that means that there's an impulse outside of the normal chain of command, which is the sinus node to the intraatrial pathways. You've got an impulse firing somewhere in the atria, and it's firing out of control. So you might have PACs, you may have atrial fib, you could have atrial flutter, you could just have sustained atrial tachycardia. But typically what's really important about this is you are finding some visualization of atrial activation. Either you're seeing the P wave, the normal P wave, which would be sinus, an abnormal morphology P wave that's coming from the atria, a rapid firing of multiple foci in the atria, which would be atrial fib, or a single focus, which is firing rapidly in a what we call a reentry pattern, meaning it fires, it goes down to the ventricle, comes back to the atria, down to the ventricle, back to the atria, and it gives us that typical flutter pattern. Those are the atrial dysrhythmias. Now, we are looking at the EKG and we make a consideration. Is this a normal P wave? Is it a P wave, but it's abnormal? Is it a fib wave? Is it a flutter wave? These are atrial tachydysrhythmias, or the progenitors of atrial tachydysrhythmias. The atria may be firing at a very rapid rate. Sinus node could be firing at a rapid rate. And now we have, in response, a ventricular rate that is greater than 100. So we're looking at the ventricular rate when we talk about the tachydysrhythmia. If we're firing from the junction, then we want to remember that depending on where in the junction you're depolarizing, you're going to actually depolarize up into the atria and down into the ventricles. And typically that's at the same time. Or it may be that the ventricles are depolarized first and the atria are depolarized second. So it just depends on where that foci is. High up in the common bundle of His, atria will still be depolarized first, but it will be in an abnormal direction, giving you an inverted P wave. Or if it's lower in the common bundle of His, and that's where your abnormal impulse formation is, you'll depolarize ventricles first and atria second. So the P wave can come after the QRS, but it will still indeed be inverted because it's an abnormal direction of conduction. And then we think about, and those are still typically a normal narrow QRS complex. So for atrial, junctional, and sinus tachydysrhythms, the first thing we're thinking about is the QRS complex narrow? Remember, less than 0.11. Now, it is possible with those dysrhythmias that you're going to depolarize the ventricles in an abnormal fashion, which means that you might have a wide QRS, but that's not the only criteria that we look at for a ventricular dysrhythm like VTAC. So your patient may have a bundle branch block, and it really is important to know the difference if the patient is stable. If he's unstable, none of it matters. If the patient's unstable, that's the easiest one for us to diagnose and treat. Because he's unstable, we're going to cardiovert, and then we're going to go forward, right? We're going to start with cardioversion, amiodarone. We're going to go forward from there. So that's what one of the beauties here is, to say that although it's really important for us to actually take a moment and think and look at what the patient is doing, it's more important about how the patient is presenting, because if he's unstable or if he's pulseless, we're going to treat him like it's VTAC or VFib. We're not going to worry about anything else if they're acutely unstable or pulseless. Okay, so we just say that in general, when we're looking at ventricular abnormalities, so that would be bundle branch block, which could be intermittent or constant, or ventricular tachycardia, torsade de pointe, or VFib, we're looking at a much wider visual of conduction through the ventricles. That's the wide QRS. So again, just thinking about this in just standard classification, traditionally how we've looked at this classification, if your QRS is narrow, generally, not always, generally you're stable. You can become very unstable. And the reason when you have narrow complex tachydysrhythmia that you're unstable is there's not enough time for the ventricle to fill because the heart is beating so fast. So at a rate of 200, 220, 240, 260, which can occur in some of our supraventricular tachydysrhythmias, there's no time for the ventricle to fill, and therefore you have a diminished pulse, you have a very severe reduction in cardiac output, and you can become unstable. Okay. In general, we're going to say supraventricular dysrhythmias, as long as the rate is less than about 240 in an adult, they will tend to be more stable. They don't tend to be profoundly unstable. They might feel bad, feel like their heart is beating really fast. They may be diaphoretic. They may feel nauseated, but they are not with a profoundly diminished pulse and a significant profound reduction in cardiac output. Their blood pressure may drop a little, but we wouldn't consider them really in a shock state, unlike when we see patients who have broad QRS tachycardia. Now, broad QRS tachycardia, that's going to encompass VTAC and all of its derivatives, flutter, VFib, torsade. Of course, very important to appreciate. Broad QRS tachycardia means that we have a limitation in ventricular filling and ventricular ejection. That's really what this is all about, is limitation in ventricular filling and ventricular ejection. Now, the difference between the supraventricular and the ventricular-based dysrhythms, or supraventricular with bundle branch block, is that in general, a tachydysrhythmia that presents with a narrow QRS still has a relationship in general between the atria and the ventricle and the right and left ventricles. Whereas when you have bundle branch block, you have dissonance between the right and left bundle, or the right and left ventricle that is associated with the dysrhythmia. And of course, if you're depolarizing your ventricles first, you completely lost the impetus of ventricular filling related to the pressure gradient from atria to ventricle and the atrial kick, which requires that you have a concise, congruent, and synchronous atrial contraction filling the ventricle. So that's really why you see the difference between that traditional classification, narrow QRS stable and broad QRS unstable. That's really important to appreciate when we're looking at those two of patients with tachydysrhythmias. Okay, so think about regular and irregular dysrhythmias that present with narrow QRS. Okay, so regular, not always, but regular will be sinus tach, atrial flutter tends to be more regular, AV nodal reentry, and tachycardias that are based on bypass tracts. So bypass tracts are tracts that connect from the atria to the ventricle, bypassing the AV junction. Things like Wolff-Parkinson-White, Langenau-Levine, lots of different bypass tract pathologies. And by the way, not necessary for every bedside nurse who takes care of critical patients to know. That's really an electrophysiology understanding. It's a high level of understanding, but it is something you want to be aware of when you're actually treating or evaluating patients. And most of the time, the reason that you would know that is because your P wave would go directly up into the QRS without any delay time. So if you happen to see that with a patient who has a tachydysrhythmia, just let your providers know the P wave is merging into the QRS. Let them figure it out from there. Let them get an electrophysiologist on board to look at the EKG. They need a cardiology reference. But the reason I'm telling you that is because those patients who I think you probably take care of, when you give them adenosine, things get worse. When you give them beta blockers, things get worse. When you give them a calcium channel antagonist, it gets worse. So if you've had those patients who've had a very significant supraventricular tachycardia, they're unstable, and you're doing your basic therapy for those patients, right? You're giving, I said adenosine, but I didn't mean that. Amiodarone, your beta block or your calcium channel blocker, those patients with Wolff-Parkinson-White or bypass tracts, they're going to get worse. So you gave them what you would standardly give for somebody with supraventricular tachycardia, and they got worse. You need to stop and say, something else is wrong here. This is not the standard. I'm not asking you to diagnose it. It's pretty intense. It requires a lot of training. And you've got to see it a lot to diagnose it. So just remember, if what you're giving the patient doesn't make the patient better, or it makes the patient worse, then what you thought you were treating is probably not what you're actually treating. And that's always really important to say, because a lot of times I've had staff say to me, well, we gave amiodarone, the patient's heart rate got worse. We gave cardizem, or we gave metoprolol, and the patient got worse. Okay, well, that typically means that there is an abnormal tract. So we're not going to talk about that. I'm happy to do a whole session on abnormal tracts because I think it's really important, but it isn't that common that you have to worry about it. Just remember in your head, when you're treating based on your algorithm, your ACLS algorithms, and you're doing the right thing and patients get worse, stop doing what you're doing, step back and say something else is going on. So those tend to be our more regular rhythms. Now, our irregular rhythms, of course, atrial fibrillation, multifocal or chaotic atrial tachycardia, which is almost always a precursor to acute onset AFib, and then atrial flutter with varying conduction. So that also, of course, will look irregular, right? Lots of times when we see acute patients, they have flutter in a 2-to-1 conduction pattern, and it's very constant. So they may be regular, but also we can see some irregularity. And patients who will have regular or irregular rhythms are those with junctional ectopic tachycardia and atrial ectopic tachycardia. What that means is the rhythm is normally regular, and then it becomes a little irregular when they have the ectopic beat. It goes back to being regular, and then it has irregularity again when they have ectopic formation. So really important, just kind of thinking about that categorization for a narrow QRS tachycardia. So again, the most important thing is my patient's heartbeat is fast, I'm immediately going to look at the width of the QRS. If I'm doing it on my bedside monitor, which is not great, but it might be all I have at the moment, I'm always going to look at two leads that have distinct characteristics. And again, my suggestion would be lead 2 and V1. And I'm looking for whether or not the QRS is narrow. If you're fast and your QRS is narrow, this cannot be a VTAC. Okay. And it typically is not going to be a bundle branch block either. It will just now be classified as supraventricular. Now, supraventricular is not a dysrhythm by itself. Supraventricular just means it's not VTAC. It's above the ventricle. So it could be at the junction, it could be in the atria, it could be in the sinus node. It's all above the ventricle. So that's a big catch-all phrase, supraventricular tachycardia. If it's broad, then we're going to think about VTAC. We're also going to think about bundle branch block, and we're going to actually look categorically at whether or not it is irregular. Now, the most common form of VTAC is a unifocus ventricular depolarization. So typically that is very regular, but it will become irregular when you have more than one foci in the ventricle firing. So again, if you think it's VTAC, you also need to differentiate irregular versus regular. And here's a time when an electrophysiologist or a cardiologist will say, especially if the patient's refractory to therapy, they'll say, just attach the 12-lead EKG and just continuously run rhythm strips, typically lead 2, V1, V6, so that we can determine if this is monomorphic, one focus, or polymorphic, multiple focus. And polymorphic VTAC is much harder to control than monomorphic VTAC. So that is really important when we're talking about tachydysrhythmias. Now, our main focus today is really talking about SVT. And under SVT, typically, we're not going to categorize sinus tachycardia because we know where the point of origin is. It's the sinus node. But when we have atrial tach or atrial flutter or atrial fib or AV nodal reentry, we're not always certain about where that impulse is. We know if we say it's AV nodal reentry, it's occurring in the node, it reenters into the atria, it circles around into the atria, down to the ventricle, back to the atria, down to the ventricle. Similar kind of philosophy here with atrial flutter. And then, of course, atrial fib, which is complete chaos. And then one or more focuses in the atria that are firing the discharge. Remember, that is almost always a precursor to AFib. Here's the thing. I see people being very cavalier, he's having PACs, and they seem to be coming from different areas. The P waves are different with his PACs. Well, by the way, that's telling you your atria is unstable. Why are you waiting until people go into atrial fib to actually have discussion about what's occurring? When you're seeing premature atrial depolarizations, you call them probably contractions, but it's really depolarizations. When you're seeing premature atrial depolarizations, that's a signal that areas in the atria are unstable. Let's try to prevent patients from progressing to these very profound, unstable tachydysrhythmias. Now, I just want to remind you again that when you're looking at the EKG, you're always going to look for a P wave, and you're going to actually, your concern will always be, looks like I got a little crazy there, a P to P interval. So I'm looking really, and it just got a little bit moved from P1 to P2, P2 to P3, P3 to P4, P4 to P5. So that's absolutely constant. P to P is regular. And now I'm going to compare that to R to R, R to R1, R to R2, R to R3, and so on. You get the drift. And of course, last but not least is the PR interval, making sure that's constant. And sometimes it's just easier to go from the peak of the P to the peak of the R, because it's just really well defined, and you're not trying to find where the beginning of the QRS complex is. Go from the peak of the P to the peak of the R. We're not trying to determine if you have first degree AV block. Remember, we're just trying to make sure that every P has an R wave and that it's congruent and constant in this categorization. Okay, so now we see our first EKG, and For me, I would never accept this EKG because there's too much movement and I need to really look at what's occurring for the patient. And you'll see here in the standard configuration, leads 1, 2, and 3, and then a lead 2 rhythm strip. So you see it lasts the whole time of the EKG. And what I'm actually seeing is P to P equals R to R, and PR interval is absolutely constant. And this is a sinus tachycardia. Now, that's the easiest thing we ever look at, sinus tachycardia. It's great because there's almost always a cause. In general, wherever the patient resides, we think about anxiety, we think about fever, we think about the patient is in hypovolemia or hypovolemic shock. Do they have activated hyperthyroidism? Their thyroid is not under good control. Have they utilized bronchodilators? Or is this a compensatory response to tissue hypoxia? So that means in hypovolemic shock, cardiogenic shock, septic shock, any kind of shock where you have not got impaired sympathetic traffic, like spinal cord injury, you're going to expect to see sinus tachycardia as a response to tissue hypoxia. And all those things will be true in ICU patients, but in ICU patients, the other aspect is patients may be on inotropes, they may be on chronotropes, they're on epinephrine, they're on Levophed, they're on dobutamine, all of which can cause a pretty significant sinus tachycardia at a really rapid rate. Do they have a compensatory tachycardia because they have low cardiac output, such as you would see in patients who have had acute, particularly anterior myocardial infarctions, where they've lost their anterior wall and they have LV dysfunction, or they have a class 3 or class 4 heart failure? They may have a rapid rate, especially if they've not been well controlled with beta blockers. And of course, with a fever, and again, hypovolemia. So we're going to look for patients. We're going to always be concerned about sinus tachycardia. So a lot of times I feel like when I communicate to physician colleagues, they're like, well, tachycardia is not worrisome. I'm not worried that the patient's heart rate's this fast. It's not really a problem. Well, it is a problem because it's an indicator that there's a compensation for a secondary problem. Now, we may have identified the problem. The patient's got a fever. I'm going to treat the fever. That should alleviate the tachycardia. But I'm always going to use sustained tachycardia as an indicator that something else is going on. So in general, in adults, and that's a general rule of thumb, rates can be as high as 150 or so. The younger you are, the little bit higher the heart rate can go. The older you are, a little bit lower the heart rate is. So typically we say 220 minus your age is about where your primary normal rest or your normal tachycardic rate is. So it's just a very generic rule. It doesn't apply all the time. And it's always important to remember there may be some subtle variations in rate that are related to breathing. So when I take a deep breath, the heart may beat faster. And when I exhale, the heart may beat slower, just like a sinus arrhythmia, but we see that with tachycardia as well. Not a profound arrhythmia, but just a little bit of difference in the heart rate. And treating the cause almost always brings that rate down. So most experts would say to you, when the heart rate is less than 150, it's unlikely, if your patient is unstable, it's unlikely that they're unstable because of their heart rate. They're typically unstable from another reason, unless they have known impairment of ventricular function. So they were admitted to you in class 4 heart failure or cardiogenic shock. If their heart rate is 130 and they also have ventricular dysfunction, that may be the cause of their instability. But in general, a heart rate less than 150 doesn't cause instability, so there's some other cause. Now, I want to make sure that you remember that whenever you're in doubt, we always need a 12-lead EKG. We've got to get it quickly. I believe that every floor in our hospital that takes critical patients, and particularly in acute patients who have our cardiac floor and in the emergency department, nurses should be highly trained on how to do a 12-lead EKG so they don't have to wait, so that we're not overburdening our EKG techs. And I need to see that EKG. I'm not just doing it for my provider. I need to see that EKG. And so I think everybody should, like in your CVICU, your MICU, in the ER, 5A, I think we should have EKG machines and everyone should be trained on how to perform a 12-lead EKG. That seems a very important component of our assessment. Now, if my patient is quite unstable and the heart rate is greater than 150, and I'm concerned and I can't really make a diagnosis, I can try adenosine and see what happens, because adenosine may not treat tachycardia, but it will oftentimes will unmask what the problem actually is. So I just want to remind you, we look at irregular, narrow QRS, irregular. There's a flutter with varying conduction, ectopic multifocal atrial tachycardia. So you have different looking P waves that occur, and you can't see them very well here, but here's a really sharp one. And then here's one that's more rounded. So you're seeing different foci, and then multifocal atrial tachycardia. So again, you can see it very clearly here, a P wave of one morphology, a very different morphology here, a different one here. You're seeing multiple morphologies of your P wave, and your P to P interval is not constant. So that's a multifocal atrial tachycardia. Now, sometimes people aren't that worried about multifocal atrial tachycardia, except that it's a precursor to AFib, and it can make your patient quite unstable because it interrupts the normal electrical contraction philosophy of atria first, ventricle second, and fill the ventricle as effectively as you possibly can. So whenever you have a premature atrial depolarization, you're not filling your ventricles optimally. Okay, so lots of other things, again, a little bit beyond what we can really cover today, but like nodal reentry, AVRT, that's a reentry accessory pathway that typically we see either Wolff-Parkinson-White type A or B, Langenau-Levine, and then this is an accessory pathway, and then this is just a reentry through the node, and the P wave will be inverted. Here's your atrial flutter. Here's some atrial ectopic abnormality, and then junctional tachycardia. Okay, but by the way, the diagnosis here is in the P wave, or in the fib wave, or in the flutter wave. The diagnosis here, you've already looked at it and you said the QRS is narrow. So the diagnosis now has nothing to do with the QRS. It's all about the P wave or the fib wave or the flutter wave. Pay attention. P wave, fib wave, flutter wave. Pay attention. Make sure the P to P equals the R to R, the PR interval is constant, and that every P looks the same. If it doesn't, you have a problem. And now you have a tachydysrhythmia and your QRS is normal, but your patient may be unstable. Okay, so if we just take a look at this EKG, my question to you is this regular or irregular? And we're going to look at that and say, oh, we can see right away that it's irregular. And is the QRS complex wide or narrow? And we're going to look at that and we're going to say right away, that's a narrow QRS. Even if I'm not measuring it, if I'm not actually measuring as well as I could, I can see it's less than 0.12. So it's a narrow, irregular, right? Irregular, narrow QRS tachycardia. So that's really important. Now, taking a look here, we're looking at these P waves, and in this case, what we're seeing in the leads, especially in lead 2, I should always see my P wave going in the same direction as my primary ventricular picture. So my ventricular picture here is upright, but my P wave is downward. That's called an inverted P, and that always tells you there's an abnormality. You should never have a downward P wave when you have an upright QRS, and this is a junctional dysrhythm. So the P wave here is inverted and the R wave is upright. That is never, 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 never normal. So nobody's asking you to be an EP doctor. No one's asking you to be a cardiologist. I'm asking you to pay attention and to make sure your provider is looking at the fact that your P wave is downward and your QRS is upright. That should never happen, and that typically indicates that you have a junctional rhythm. The problem is, of course, as much as I love P waves, I also recognize can't always see the P waves. Sometimes the atrial depolarization is really small. Sometimes when the heart rate is really fast, I can't see the P waves. So now I'm going to really just focus on the width of the QRS and say, I know it's not ventricular no matter how fast it is, but I really can't see my P waves. And again, I'm going to think about what can I do with my lead placement? Can I get a 12 lead EKG and find some leads where I can see the P wave and then run a rhythm strip in those leads? So here we have somebody who's really got a very rapid rate. And when we look at this, we really can't make a case for P waves. This is really your inverted T or your ST segment that's coving downwards, and then your T wave is not really your P wave. And you really can't see the P waves in this patient. But they do have a very narrow QRS tachycardia. Okay, now I look at this and I say, look, I'm looking for P waves. I don't see P waves. What I see is this irregular pattern here. In one lead, I see this kind of sawtooth look. And then in a different lead, I just see kind of an irregular electrical activity in the atria. Is this fib or flutter? And is there a difference? A lot of times I hear people say, it's fib flutter. Okay, what? You can't correlate the difference, because there is going to be a difference if the patient is unstable. How we're going to treat a fib and how we're going to treat a flutter in an unstable patient can actually be quite different, and we need to know what to expect. So if at all possible, we want to be able to make the diagnosis, whether it's atrial fib or atrial flutter. So a couple things that are really important when we're talking about unstable tachydysrhythmias, okay? With atrial flutter, the atrial rate, that would mean flutter wave 1 to flutter wave 2, typically a little bit slower, 250 to 400. I mean, 400 is pretty fast. Thank God you don't conduct through your AV junction at that rate. You'd be dead, right? You'd be dead immediately. So the AV junction is protecting you by not conducting every flutter wave. But that flutter wave, actually, the wave itself may bypass the AV junction. That's really important. But the junction cannot appropriately conduct. So your ventricular rate is going to vary with the conduction of the flutter, right? The rhythm of the atria is regular. The rhythm of the atria is absolutely irregular. Now, the ventricular rate may be a little bit irregular, but the rhythm of the atria is regular. And this is basically what we call a re-entry by a large recircuit, not a bypass, an abnormal bypass circuit, and typically is a single or maybe a dual focus firing. Whereas a fib, traditionally, the fib wave 1 to fib wave 2 is 350, 400, up to 500. The rate in a fib wave is up to 500. So if you're not looking at the flutter wave or you're not looking at the fib wave, you're not using your diagnostics very well. The rhythm of the atria is grossly irregular. And sometimes your ventricular response can be grossly irregular. Sometimes it can be very regular, just depends on the conduction pathway through the AV junction. But when we look at the pattern between flutter and fib, when we look at flutter, there is a sawtooth baseline. I'm going to show you something very wonderful. Probably already know it, but it's going to help you a lot. With AFib, you have a wavy baseline, right? It's not really a regular reproducible atrial pattern. It's multifocuses, typically many foci firing in the atria, all having a different visualization. And again, thank God the AV junction protects you from conducting that. Okay, my grandson is going to come in here. Come on, you come over here. He yesterday, his friend pushed him down and his canine actually went up into his jaw. So I'm taking care of him today. And tomorrow he's going to go to the hospital and have a little surgery. You want to say hi to everybody?
Hi.
Hi. So he just likes to check in and make sure I'm still here. He's playing with my husband, but he likes to check in and make sure I'm still here. Okay, so this is a 75-year-old female who has a history of diabetes and hypertension. This is her basic routine EKG. She looks pretty good here. You have a little bit of irregularity. She looks like she's got AFib as an underlying diagnosis, but today she comes into the ECC, and now you see she's quite irregular. Okay, right as soon as you see that she's this irregular, you almost immediately are going to say this is not VTAC, because VTAC is almost always, remember, if it's monomorphic, it's almost always regular. And then we look at the fact that over here, she's got this very wide looking QRS, but this is actually a left bundle branch block with fast atrial fibrillation. So she's not very well controlled. We got to control her rate, and she needs to get referred on to cardiology. We're going to control her. So we're going to remember with atrial fibrillation, our aim is to control the ventricular rate, prevent patients from having stroke, looking for the cause of the AFib. If it's acute, almost always acute AFib in your care occurs because your patient's had a pulmonary embolism, because they have hyperthyroidism, or because their atria is volume overloaded. Oh, that's a very common cause of atrial fib inside the hospital. So we're going to really look for that underlying cause. Remember, the things that we look for and treat are going to be a little different in patients who have chronic AFib, but we're going to always try to identify and treat their complication. So first and foremost, if the patient is unstable, we're going to control the ventricular rate. We do that with beta blocker, calcium channel blocker. Sometimes there may be consideration, depending on your cardiologist, of controlling with digitalis. Now, if we've referred to a cardiologist, they may start the patient on flecainide. We are always going to give that patient amiodarone. Another agent that is available to us with electrophysiology on board and cardiology on board. Another agent that's available to us is sotalol, which is a marriage of a beta blocker and a potassium channel blocker. I'm going to go see what Don's doing. All right, good job. Thank you. All right, and of course, okay, that's great. Thank you so much. Okay, and then to prevent stroke. So we're going to use aspirin, we're going to use warfarin, Eliquis. Sometimes we use direct thrombin inhibitors. We can use other kinds of agents depending on heart failure scores. All right, so take a look at this. Pretty much you can see this is a regular sawtooth pattern. Now, you're not seeing it blatantly in every lead, right? You can't see it that clearly in lead 1, not seeing it that clearly here in V2. You see it quite clearly, though, in lead 2, V3, AVF, and really over here on those left-sided chest leads. But here's what I'm going to tell you. Turn it upside down. Okay, that's one of the easiest diagnostic tools ever. You don't even have to measure anything. Turn it upside down, and you can see that the flutter waves, look exactly the same when you turned your EKG upside down. This is one of the best diagnostic tools for atrial flutter ever known. All right, the other thing that's really important when we look at unstable tachydysrhythmias is that adenosine is both diagnostic and therapeutic, right? We really love to give adenosine when we have narrow complex tachycardia that is at a rapid rate and that actually may be promoting some drop in blood pressure and some clinical symptomatology that we're concerned about, diaphoresis, nausea, etc. So very important, first and foremost, if you have time, be sure that you have attached 12 lead EKG and you are running a rhythm strip in lead 2, V1, V6. You give that adenosine. The beauty of adenosine is it is so short acting. If it wasn't the right thing, it's going to be gone really quickly, right? And that's really great. Now, what adenosine primarily does is it blocks conduction across the AV node. So this is going to help us when we're looking at rhythms that are AV nodal disorders. So any kind of rhythm that arises in the atria and communicates down through the junction. And also, if we're talking about re-entry, so AV nodal re-entry dysrhythmias, atrial flutter, which is a re-entry dysrhythmia, this is going to terminate that tachydysrhythmia. And if the circuit is above the AV node and it's not about the nodal dysfunction, it will temporarily slow down the heart rate, which will allow us the ability to look at what the problem is. So remember, our primary focus here with SVT, block the AV node, control the ventricular rate. And if you've got stable, narrow QRS tachycardia, we're going to give you adenosine bolus times 2. You can actually give 3, 4, and 5 adenosine boluses, but typically we say we're going to give you 6, we're going to give you 12, we're going to give you 12. You can then move to 18 or 24, but it really depends on your physician's comfort. If it's a cardiologist, if it's somebody really comfortable with cardiology, but typically it's 6, 12, 12. Now, if the patient's dysrhythm suddenly terminates and stays terminated, that's an AV nodal reentry tachycardia. You stopped it, we're done, fantastic. That's what you're going to expect. If there's no effect, this is typically a junctional tachycardia or a sinus tachycardia at a very, very rapid rate. So really, really important to appreciate that adenosine isn't going to affect those patients. But in patients who have atrial tachycardia, multifocal atrial tachycardia, atrial flutter, or rapid rate atrial fibrillation, it will slow the ventricular rate because it slows the conduction through the junction, and you'll be able to figure out what the problem is: multifocal atrial tach, junctional tach, flutter, or fib. So that's the beauty of adenosine. It's both therapeutic and diagnostic. So here's a patient who gets adenosine. You can see it unmasks that the patient is in atrial flutter. This patient has atrial flutter. Now, we didn't control the atrial flutter, and adenosine is short-lived. So we're going to have these pauses, and then the patient's going to resume his tachycardic rate. So when I hear nurses say, well, we gave adenosine and patient responded, but then he resumed his tachycardia, well, then he didn't have AV nodal reentry. And that's really what adenosine is for. So now I get the opportunity to look at the patient and say, oh, look, this patient's got atrial flutter. When he resumes his rate again, I'm going to do the thing that's the very best thing for atrial flutter, and that is DC cardioversion. That's going to be the most important thing I can do. So I've made a diagnosis by giving my patient adenosine. Here's another unmasking. Look how rapid that rate is. And the patient gets adenosine. This patient has atrial fibrillation, not atrial flutter. And you can see that because you see a lot of variability here, and the baseline is really quite wavy, and it's not reproducible. So I'm gonna end here today, and I'm just going to say AF, small f, that's fib, and AF, capital F, that's flutter. I want to really look at the differences in these two. AF flutter is curable in 80 to 90% of patients. The way you stop flutter is cardioversion. So I might give you adenosine because you have a rapid rate. I'm using adenosine. Your provider might say, give adenosine. Let's see what's going to happen. And you have a slowing and then a resumption. Then you say, oh, the adenosine didn't work. Let's do more. No, you got your patient unfolded what the problem is. Now the patient needs cardioversion, and if they have recurrent atrial flutter, they will have recurrent cardioversion, but they're going to need an ablation. So 80 to 90% of patients can be cured by ablation. Atrial fibrillation is not always curable. It's just manageable. We control the rate typically with CCB, calcium channel blockers or beta blockers. I'm such a bad speller. My fingers go too fast. Not usually responsive to cardioversion, and generally not readily available for ablation. It just really doesn't work because you have multiple foci. So a big difference between AF, small f, AFib, and A flutter. So again, just want to remind you about responding to adenosine. This patient is actually in an AV nodal reentry tachycardia. Once he got adenosine, he sustained the reduction in his rate. And here's another patient who had a beautiful response to adenosine, but what you actually see here is that your patient has multifocal atrial tachycardia. So again, that didn't fix that atrial tachycardia, right? It delays that conduction through the AV junction. If the AV junction is the problem, adenosine works. If the AV junction is not the problem, what it's going to do is give you the opportunity to evaluate what has occurred for your patient. So instead of looking at the monitor, looking only for a reduction in rate, you are evaluating, hopefully, on rhythm strips, if possible, or recording from your bedside recorder, dual channel EKGs, because you're going to unmask what these other problems are. So want to just wind this up with my last statement here. Failure of tachycardia to terminate after adenosine. So you might see slowing, but then it resumes. Remember, sinus tachycardia, not going to terminate after adenosine. Atrial flutter, not going to terminate after adenosine. Don't keep giving adenosine. Now move to cardioversion. Patient will typically then be put on calcium channel block or beta block. Rarely digoxin, might be some other agents we're going to look at for a more chronic therapeutic intervention, but we're going to cardiovert because that is the treatment of choice for atrial flutter. And for multifocal or ectopic atrial tachycardia, that you will not be able to terminate that after adenosine. You're going to use CCB, beta block, and for short-term use only, amiodarone. Okay, so that's the first chapter, not the last. The first chapter in unstable tachydysrhythmias. Next week, I'm going to continue on. We're going to talk about a couple of other things. And if there's a desire on 2 weeks from today, I'll talk about Wolff-Parkinson-White and other accessory pathways. Again, they're relatively infrequent, so I don't always talk about them. Thank you so much for attending today, a wonderful Wednesday. I'm going to stop my recording and I'm going to say, see you next time tomorrow for stiff man syndrome, next Wednesday for a continuation of unstable tachycardia. I hope you've learned something today. Thank you so much for spending time with me, for taking time to be together and learn more about the care of our patients. Thank you so very, very much.